Dear Chair, dear audience, I would like to present my research topic, which is the effect of cognitive trainings on neuroplasticity in mild cognitive impairment. I'm Eszter Radics. My supervisor is András Horváth, and my SMS is Marie. My statistician is Silvia Kisdala, and my vision is that all preventable dementia cases are prevented, and my mission is to evaluate cognitive trainings to delay prevention or prevent dementia. Here you can see my specific goals. I have 2 ongoing projects. And let's jump to the first one, which is investigating the effectiveness of cognitive trainings in adults. So a little bit about the background. Dementia is on the rise and will affect 139 million people by 2050. There is no cure yet, but different lifestyle interventions show promising results. Previous studies showed that at least 40% of all dementia cases are linked to modifiable lifestyle and environmental factors. And there are a wide range of cognitive trainings, but their exact effect on objective neural parameters is still unknown. So our clinical question is, how does cognitive training influence structural and functional network connectivity and metabolic changes in the brain? Our population is adults. Our interventions are designed and validated cognitive trainings, and we included all kinds of control groups that didn't include a cognitive training. Our outcomes are objective biomarkers of cognitive risk, such as MRI. Our hypothesis is that cognitive trainings have a beneficial effect on the brain compared to no intervention. Here you can see our search key. We conducted the research in 3 databases. And we ended up a bit more than 6,000 records, and we ended with 22 eligible articles. And here you can see the progress of this project. I've just finished the risk of bias assessment. And we still have 1 ongoing analysis with the fMRI data. And we finished analyzing the structural MRI and the diffusion tensor imaging data. One of these DTI metrics is fractional anisotropy. This is a scale between 0 and 1, where 0 means that diffusion is equal in all directions, which indicates a reduced structural integrity or white matter disruption, and 1 means unidirectional diffusion, indicating aligned fibers and white matter integrity. We choose this outcome because this is sensitive to white matter degeneration in the early stages of Alzheimer's disease, including MCI. Here you can see the results of this analysis. Here we analyzed a healthy population. You can see the changes between the pre and the post values of the intervention and the control groups. We included 4 studies with a population of 115 people. The heterogeneity is pretty high, it's 87%. This could be due to the cognitive trainings differences and differences in the control conditions as well. The mean difference of 0.01 is not mathematically significant, and we also do not consider this clinically significant, even though it shows a positive trend. The next outcome we were assessing is hippocampal volume measured by structural MRI. It is associated with late life cognitive decline, and a smaller hippocampal volume is associated with poorer episodic memory, processing speed, working memory, verbal learning, and executive functioning. And these cognitive domains are very vulnerable to decline in non-pathological aging. Here you can see the results of this metric. Here you can also see the change between the pre and the post values. These are mean differences. We also included 4 test studies in this analysis with a population of 315 people. The heterogeneity is 0%, but the wide confidence interval indicates that it's a bit more high. The mean difference of 29.79 is not mathematically significant again, and we also do not consider this significant clinically. A bit more about clinical significance. So cognitive trainings are widely advised, even though their effect is not yet evidence-based. And these results should suggest a positive tendency, so it's worth investigating what makes significant studies successful. A previous meta-analysis on neuropsychological outcomes stated that the efficacy of cognitive training varies across cognitive domains and is largely determined by design aspects of the cognitive training, which we consider true for these outcomes we were measuring as well. Our implications for research is to standardize cognitive training's length, a better randomization, ensuring no baseline differences, and standardizing data reporting and reporting all the data could help. The strength of this study is that it is the first analysis of these objective parameters. We included different populations and different outcomes, but our limitations are heterogeneity in the intervention and the control conditions, small sample sizes, and baseline differences in groups. So let's jump to the second project. It is advancing initiatives of dementia risk reduction. This will be a survey about the background. An interdisciplinary viewpoint is emerging in dementia care, including the understanding of need and opinion of people involved. We know that compliance is dependent on how well people work together, and we believe that personalized medicine could lead to improved quality of life and health and disease-related behavior. Our clinical question is that what are the components of priority of prevention for patients, clinicians, and caretakers? Our population would be patients at risk of dementia or with dementia and those involved in their care. The factor would be the social factors of importance, and the context is primary, secondary, and tertiary prevention. The clinical and research implication is to design interventions and communication strategies tailored to patient and caregiver priorities, and to improve adherence and compliance. A little bit about the method. We are organizing a focus group based on the European Working Group of People with Dementia. We are including healthcare professionals, patients, as well as informal caregivers in this study, and we are using surveys to understand the needs of clinicians and patients. So here you can see the summary of my project with the planned submission date. And I would like to thank you for your attention with the quote of Aldous Huxley: "Systematic reasoning is something we could not, as a species or as individuals, possibly do without. But neither do we. If we are to remain sane, can we possibly do without direct perception, the more unsystematic the better, of the inner and outer worlds into which we have been born." Thank you.
So regarding this survey about prevention of dementia, how many surveys, persons, patients, physicians do you want to approach?
I think the focus group would be around 20 people. And we are having, I've translated 2 surveys that they used in the Netherlands and in Australia. It's not that long surveys, and we are doing our own surveys as well. So it will be like 4 or 5 surveys, most probably.
And 20 people per survey?
Yes, around.
Around, okay.